an integrative and multidisciplinary approach with case examples. For this, may we request Professor S.K. Rajan, who is going to chair the session, and he needs no introduction. He is from the Tamil Nadu Dr. MGR Medical University, Chennai. And co-chair persons are Dr. Geeta, who is on the way, and when she comes she can occupy the chair, and Dr. N. Jayavelan, he will come, he is also expected to be here very shortly. And Dr. T. Rama Raghu will coordinate the case examples. Over to the chairperson. Thank you.
Can I request Dr. Rama to come over to the stage? Ladies and gentlemen, good evening to all of you. I hope all of you enjoyed the morning session. And now we have got an entirely different kind of deliberations. Dr. Rama Raghu is Clinical Director of TriMed Group of institutions. She studied MBBS at Stanley Medical College. She was my student. I am so proud. I was her teacher, professor, and she did her MBBS in finished in 1992-93 or some time around, and worked in the Department of Neurology, VHS, under Professor Krishnamurthy Srinivas. And afterwards, I was wondering, really, I thought she would become obstetric gynecologist and all. She has taken extra interest in epidemiology. She did her MSc in London, her MSc epidemiology, and so the tropical medicine is a very interesting topic for me, especially tropical medicine is more neglected. You could have seen hypertension conference, diabetes conference, cardiology conference, neurology, and very recently we organized what is called infectious disease conference. These are all neglected areas, infectious disease, tropical medicine. That's why I requested British High Commissioner to sponsor the program for 2013 for organizing tropical medicine conference, tying up with the Royal College, Edinburgh. So this, I am very happy Rama has done tropical medicine and epidemiology. Epidemiology, every one of us should learn something. Otherwise, it's very difficult for us to publish the paper. So whoever is qualified in epidemiology, they can interpret any kind of paper publication. They may be the very good guide for them. And I appreciate your interest. Now she takes care of the patients in TriMed group of institutions, wherein they are dealing with what's called alternative medicine kind of thing, about which she is going to now deliver the lecture with the case studies, how she is able to manage some kind of problems which is related to all systemic diseases. Say for example, if a person is coming with arthritis, immediately people like us would think, why not we give some non-steroid anti-inflammatory drug or some kind of injection of hydrocortisone in the joint. Because 60 plus people invariably have got osteoarthritis. They want, whoever comes to the doctor, they want 4 things. Number 1 is comfort. Number 2 is control. Number 3 is maintenance. Number 4 is cure. But we are considering cure is the last thing. We will do the best for comfort and control, and rest we leave to the God. That is what's called cure. But the patient will come and tell you, I want complete cure. That is what is happening whenever people come there. But the duty of the doctor is to provide quality to the life of the patient, irrespective of the disease. That is what Dr. Rama is going to talk about. Their main aim is to provide quality to the life of the patient. What is the quality? To alleviate the pain, alleviate the discomfort, See, you must know all the disability people need not necessarily have difficulty. The theory is when a patient has got a disability, whereas he is not having any difficulty, why should you intervene at all? So, but people who are not having disability, who got difficulty, we must give them comfort and control, which is done with purely non-medical intervention, non-drug, non-injection intervention. That way, they are the pioneers in the city of Chennai. They started one center, first in Anna Nagar. Subsequently, they have started in Thenambet and Thiruvanmiyur. And I am very happy. The response is really amazing and very, very inspiring kind of work. Many of my patients go there, they come back and thanking me that I referred them to a place where they don't give injection or drug. And this particular thing is not included in medical curriculum. I was the chairman of higher specialties, Tamil Nadu Medical University, 5 years. And I was the chairman for curriculum committee. And I was chairman for family medicine. From 1999 onwards, till this day, I am attached to the university. I was nominated as advisor to Tamil Nadu Dr. MGR Medical University, still continuing there. But we are failing in all our attempts to include some of the things in the curriculum. This alternative medicine was very much like, there was a question raised in 1998 in the parliament. Why not we have separate department in all medical colleges throughout India for alternative medicine? They sought the opinion of all senior professors of the whole country. And then Stanley Medical College, Dean asked me to submit my opinion. I asked him, we will organize council meeting wherein there are 90 professors. We wanted their opinion. Believe me, 99% of them would not vote for favor of alternative medicine. They said these people should not enter into the medical college. I was the only person, 1997, I was the only person supported why that particular department must be there. We are always blindly following the Western textbook, forgetting we have got traditional methods of curing some of the ailments. We have got wonderful traditional methods. But we always try to follow the textbook, what is called evidence-based medicine. So if somebody is admitted in corporate hospital, they, in addition to evidence-based, the institution-based, institution instruct them to submit the patient for MRI or CT scan, so on and so forth. The target is to see that a patient is spending 10,000 rupees or something like that. So I'm not trying to, accuse people or try to level charges against them. There are so many ways according to our people. Our people need. So a best doctor must treat the patient, keeping himself in the patient's place. Keeping himself in the patient's place and seeing that we are treating what patient needs, not whatever we know. We know a lot of things, lot of theories, lot of textbook we have mastered. We need not do that. That is what I think Rama is going to project. So, sorry I have taken some time because being a senior professor, it is my privilege. It is privilege because I am experienced. I am also in the editorial board of Davidson textbook. So I myself have committed a lot of things which is not practically possible or feasible to the poorest of the poor in the rural side. But what to do? We have to go along with the people who need. For textbook distribution, the editorial needs something which I have to necessarily do. But I am a very successful practitioner. I do what people need, not whatever I know. So over to Dr. Rama.
Good afternoon, everybody. I'd like to first thank Dr. S.K. Rajan for his kind introduction and also the organizers and Dr. E.S. Krishnamurthy for this opportunity. It really is a privilege to be here today. So today I'll be talking about how comprehensive multidisciplinary assessments paved the way for an optimal integrated treatment program in elder care. So today we have two patients, one a true elder, a 71-year-old gentleman, and another young elder, a 52-year-old gentleman. And the first is a patient who came to us with a neurological disorder, and which had a very fluctuant course in terms of his developing medical complications along the way, and then how he stabilized with medication along with an integrative medical program. And also an out-of-the-box intervention was thrown in the middle as the treatment went on, and how that intervention along with everything else we did could have modified the outcome of the treatment. And the second patient, like I said, is a young elder, and he came to us with a recurrent stroke, and how he dramatically improved with medication along with the other non-invasive interventions that we gave him for a period of 2 to 3 weeks. So the first case is a 71-year-old gentleman, a known diabetic and hypertensive for the past 15 years, and with a history of progressive cognitive deficit for the past 3.5 years. And that consisted of immediate recent memory deficit at onset. And he's been having problems in planning and in business interactions, and he's not been working for the past 1.5 years. 1 year ago, that was 1.5 years ago when it started at onset. 1 year ago, he became more confused. He had bladder and bowel problems. And there was a lot of bizarre behavior, like you can see. There was aimless carrying of books to the car, to his room. He used to keep going to and fro. And grabbing of wild plants from the workplace. He had many factories, so he was grabbing wild plants from there, loading his car with it. There was disinhibition, so during one particular examination with one of our neurologists, he broke into song and dance when she was a rank stranger. He had met her for the first time. And the family reported severe sleep disturbances, and then he was started on risperidone 1 milligram a day. Around 2 months later, there wasn't much in terms of improvement. Actually, it got worse. There was increase in behavioral problems. There was disorientation to place, time, and person. He was agitated and restless. The family was having a very hard time managing him. He used to get angry if the house was locked. He felt threatened, as if they're just locking him in. He wanted to go out. A lot of perseveration, that is repetition of statements. And there were times when he was very quiet. He just used to be withdrawn. And at this point, he was totally dependent on his family for his activities of daily living. Now, pre-morbid personality, very interesting. As you can see, he's an electrical engineer, a B.Tech, in the times of yore. Highly innovative, very research-oriented. He's invented a large number of equipments for factories, and he holds patents for many kinds of gadgets which are still being used in factories like Neyveli Lignite Complex. And so these ranged from rare electronic equipment to perfume factories. So that's a lot of stuff happening there. And he closed some factories 10 years ago. But he still has a techno lab which is run by assistants. He's not doing anything there. And I must talk about his family. He's got 5 siblings and an amazingly supportive family, because at the time when he was with us, when he came in for an examination or in the hospital, there were at least 5 people with him, and no amount of telling the family that the hospital rule says there should be only 1 or 2 people just didn't get, they just didn't agree with all that. So they said he's going to be happy and we are going to be peaceful only if so many of us are with him. So at a time there are always 5 people along with the patient. And this is a family of very high academic achievers. One is a retired IAS officer, and he is married with 2 daughters. He separated from his first family, from his wife and the first 2 daughters. And he's been in a relationship, in a second relationship for the past 15 years, from which he has a daughter. Listen to the patient. He's trying to give you the diagnosis. This is an oft-repeated statement made by Professor Srinivas when we used to work. With all of us who worked with him, we never forget this. So this is what we base our multidisciplinary assessment on. So we have this team of well-qualified and trained professionals. We have the allopathy physician. Along with that, we have the Ayurveda physician and the yoga, naturopathy. They're all doctors. And we have the physical therapists, the social workers, the psychological therapists. We are all there to listen to the patient. So what one person probably misses out on, another person picks up. So it's a very multi-dimensional, multi-domain kind of assessment. And everything when it's put together comes out with a lot of problems in many dimensions. So a disorder can have many dimensions. So this really helps with that. So on this multidisciplinary assessment, we found that this man was poorly oriented to person, time, and place. He had immediate and recent memory deficits. He could follow just some simple commands. There was no motor or sensory deficit. On psychological testing, there was impairment of visuospatial functioning and problems with comprehension and executive functions, and there were no long track signs. Now, coming to the investigations, we really looked at a lot of reversible. I think we looked through all the reversible causes for this kind of condition. So first, there were the blood tests, the B12, the folate, the homocysteine. We looked at all that, any infection, and VDRL, HIV, TPHA, anything which is sexually transmitted, and MRI brain, which just picked up age-related cerebral atrophy. There was nothing else. The EEG showed some slowing, and some triphasic waves could be indicative of an encephalopathy, possibly metabolic. The vitamin D levels were low, as it is in a lot of people here in India across ages. And the other blood tests, like I said, were normal. So summarizing, this is Mr. S, 71 years old, clinically diagnosed to have a probable Alzheimer's dementia. Like I said, we had ruled out all reversible causes. And he has been in treatment for dementia with medicines, with the medication for dementia, donepezil, memantine, and antipsychotics for his behavioral problems. And then a balanced diet, vitamins, and of course the rehabilitation procedures. So during the course of the outpatient treatment, after the assessment and the medications had been started, we formulated an integrated medical program for him, which lasted for 14 days in the hope that there would be some response from him. So he underwent this program of Ayurveda that consisted of 5 days of short Shirodhara. In Shirodhara, you have medicated oil which is poured slowly on the patient's forehead. It is supposed to calm down a restless patient. And this was followed by 9 days of Abhyangam, that is full body oil massage with warm medicated oil. This strengthens and nourishes the muscles of the person and also helps in relaxing the patient. So what happened here is, in the middle of the session, he used to get very restless. He wanted to get out of the room. So we had to shorten all these processes. So then you have the short Shirodhara, that's our version of the treatment. It was a procedure which lasts for 1 hour, had to be shortened to half an hour, both for Shirodhara and Abhyangam, keeping his mental state in mind. And along with it, we tried some exercises, tried to make him do some exercises in physical therapy, some breathing exercises as yoga therapy. And there was a lot of caregiver counseling, like I said, a lot of anxiety from different parts of the family. There were people who were out of station who used to call us and ask us. We used to communicate with all of the people who were with the patient. That was 5 or 6 at a time. In spite of that, we had queries from doctors, relatives, from outside who used to call us, and then we had to explain things to them. So a lot of talking and communicating, which is really very helpful, I think, in a case like this. In any other case for that matter. So with all these interventions for 14 days, I wouldn't say the response was very encouraging, but there was a slight reduction, at least subjectively, in restlessness and agitation, but he still spoke very little. So when he used to come and meet me, he'll just sit in the room. He'll be brought in with three people of his family. He'll sit down, and very poor eye contact. And then he'll just look around somewhere, get restless, and he'll want to go out again. So that was the kind of meeting we used to have. So it wasn't really very encouraging. Now, along the way, 6 months, so this was around 8 to 9 months ago, he underwent the program. And 6 months ago, the patient's family again came back to us saying that he had complaints of drowsiness, very poor intake, so he was admitted in hospital with cough and fever. He was very bedbound, he had some bed sores, the speech was scanty, he was incontinent, fluctuating sugar and BP levels. And then we investigated him again like we usually do in hospital, and then we treated him for aspiration pneumonia, urinary tract infection with antibiotics, intravenous. And then we adjusted his antihypertensives and the sugar medicines with insulin and oral hypoglycemics. And then we had to insert the Ryle's tube and Foley's catheter because of incontinence and there was very poor intake. So like I said, these were the medications, quite a few, supportive and some therapeutic, and supplemented with vitamins and calcium. Now, along with the medication, we started off the intensive rehab also in hospital. So there was mobilization in bed by the physiotherapists. They used to come in twice a day. And then we slowly got him out of bed within a week. And we also tried acupressure because the family was surfing and they wanted to know what were the effects of acupressure. And he was complaining of a lot of pain in the hips. So when we used to try to mobilize him, he used to complain of pain and wince, because he never used to say that he had pain. So he used to wince, and that's when we thought we could use some acupressure. So we got a yoga and naturopathy doctor in, and he used to come once a day and do acupressure. We don't do acupuncture, but we do acupressure. So that could be a little painful for the patient, but we thought it would be worth the try. So we did that for around 10 days. And this was supported with patient family counseling. We attempted CRT and everything else we could do for the patient, but we couldn't gauge the response because he used to be very quiet. And of course, like I said, the caregiver counseling was essential at various levels. So at this point, like I said, we had a family of very high academic achievers, and there was this brother who was really looking to the net. He had an iPad. He said he was very happy with the invention. It was very easy for him to go on surfing through things, and he came up with this report about a doctor called Dr. Mary Newport in Pennsylvania, and her husband had acute onset cognitive decline, memory impairment, motor problems, and behavioral problems. And she found out that the coconut oil therapy worked for her husband. So the rationale behind using this is there's the availability of ketone bodies, which is not actually available not present in humans unless they are starved or they're on a special Atkins diet kind of thing with low carbohydrate. The ketone bodies help the brain cells, which are insulin resistant and do not take up glucose. They provide energy to the brain cells. So that is the premise of using coconut oil. And this medium chain triglyceride is the component in coconut oil which is metabolized in the liver to ketone bodies. And these ketone bodies are used by the brain cells, and they use it up for energy, and that's how they bring about some cognitive repair. So like I said, the coconut oil is a natural element which is very rich in medium chain triglycerides, about 60%, and it also contains omega-6 fatty acids and other long and short chain fatty acids. And the final metabolic product is a beta hydroxybutyrate, and that is what helps the neurons get some energy. And the recommended dosage is 35 ml of coconut oil according to her per day, which has 20 milligrams of MCTs, and it can be mixed with the food and consumed orally. So I went to the literature, and there's quite a deal of skepticism about coconut oil. Some people have just thrashed it around and said, and they still believe in the comprehensive lifestyle where you include a rainbow diet, and there's lots of sunshine, and you have your fruits and vegetables, and then you exercise. There's mental and physical activity. And then what would complete a happy picture would be a good physician who understands the complexities of the patient, and then who contributes towards a happy aging. So there are still a lot of supporters for that. So there have not been enough trials to prove that it really works, but there are only some anecdotal studies, like they called it, during the review of the literature. But nevertheless, on the request of the patient's brother, like I said, reviewed the literature and thought it would be worthwhile to try out the coconut oil. And we started with 20 ml given to the rice tube, because he was not taking any oral feeds at that time. And over 1 month, we gradually increased it to 40 and then to 60 ml per day. There was a lot of monitoring because he was diabetic. And the coconut oil is supposed to, maybe cause a lot of fluctuations in the sugar levels. It is an absolute no-no with a lot of diabetologists, with everybody we met. So there was strict monitoring. We had a diabetologist on board who was taking care of his sugar levels. And when he hit 60 ml in 2 days, he had a lot of GIT intolerance. He had diarrhea. So there was a slip in the general condition of the patient. So we then again went back to 40 ml per day, and that really worked well. So the clinical status on discharge, he was there in the hospital for 6 weeks. So in the first 2 weeks, we stabilized him with medication and the rehab, like I said, physical therapy and all that. And for 4 weeks, that was the time when there was a baseline where there was no change in pharmacotherapy or the metabolic status, and he had only coconut oil. So that was escalated, like I said, from 0 to 60 ml and then back to 40 ml at the end of 4 weeks. So this is what we found. He was able to walk with assistance, with ongoing physiotherapy and all the other interventions. So walked with assistance, there were no bed sores, there was an increase in spontaneous speech. But it was never with us when we went, but the family said he used to talk to his sister who was out of station. He used to talk to the other members of the family, but never to us. It was very little. He responded to some simple commands and questions. And like I said, he was communicating with his family quite well. He was able to have 300 ml of oral intake. We were trying alternate oral and rise tube feeds, so comfortably taking 300 ml of oral intake. Sleep patterns became very consistent, but he could not be bladder trained even at this point. So we tried clamping the catheter, but it didn't work. So he was discharged after 45 days. Now there are two reasons for him staying in the hospital. The first one was the family wanted us to monitor his status with the coconut oil. So they wanted him to get on to the optimal dose of coconut oil and then go home after it stabilized. So that took some time. The second was they're very particular about getting their house arranged and properly for his going back. So he was actually staying in a second floor home which didn't have a lift. So they moved to a house and they redid a ground floor house, and then they got nurses right round the clock, a physiotherapist and all of that. So they wanted all the arrangements to be really good before he went home. So that took around 1 month. So that's why that explains a long stay of 45 days. So as outpatient, they continued a home-based physiotherapy. They had a therapist coming in twice a day. There was acupressure. They had an acupressure person coming from outside. It was not our doctor who went, but they had somebody coming in and doing an acupressure intervention every day. And from our side, we did a weekly Ayurveda therapy, and we tried some yoga breathing exercises at Anna Nagar, where we have a center, once a week for a month. Now the present status is like, as I saw him 3 or 4 days back. Now the point here is, you have to believe what I'm saying, because the family did not permit us to do a video. So we don't have anything to show from our side, but believe it or not, this is his present status. Spontaneous speech has improved significantly. He also walked in Dr. ESK's outpatient that day and wished him, and he responded to whatever was asked. Though it was brief, it was so much better than it was before. It was the occasional agitation, more interactive with family members, walks without support. He's been off the rise tube, we just pulled it out, and he's having adequate oral intake. And then he went back to the urologist with a urinary tract infection, and that was, the catheter was pulled off. He's in the diaper, and now he at least indicates many times that he wants to use the bathroom, the restroom. So this is the first patient. The second, we'll move on to the second one. Like I said, it's a young elder, a 52-year-old gentleman. Yeah.
This really I congratulate Rama for a wonderful presentation. Friends, this is one place you have to remember. You would have read a lot of things in medical literature. There is no mention of extreme tolerance, endurance, empathy and sympathy. They are all not mentioned in textbook, which you can see. All these 4 things are operated over there in this patient. Number one, the team of people dealt with the patient were extremely tolerant. And, they endured a lot of things. How many times they would have objected. Many of the doctors, relatives of the patient would have come and disturbed them. What evidence you have got to use coconut oil? So many hurdles they would have come across. But they were successfully convinced them, and they were able to give the quality to the patient. I tell you frankly, if same thing has happened somewhere, and patient developed this aspiration pneumonia at the age is 70 plus, what is the age?
71, sir.
70 plus people, whoever develops this aspiration pneumonia, they would have landed up in trouble. They would have been dead. Unless the teamwork is successfully operating and convincing the people, doing what patient need was more important than what they know. Otherwise, based on the protocol, they will immediately do the ABG and oxygen level, saturation. If carbon dioxide is more, pH is less, it is respiratory acidosis. Carbon dioxide is less, oxygen is more, pH is low, it is metabolic acidosis. They will put in the ventilator, patient will die of ventilator-related pneumonia. This is what we are dealing with. Now it is completely must avoided, knowing pretty well this alternative integrated therapy may work out well. Maybe in the years to come, it may be included in the curriculum, and even allopathic doctors may certainly take up this kind of lesson from the experienced people. In future, we can adopt this strategy side by side. This is a really best example. Otherwise, you would have lost in 3 stages, 3 places. Either community nosocomial infection, when catheter was introduced, almost 60 to 70% of the people, they develop what is called hospital-induced infection, nosocomial, in bladder catheter, which is not there. That much amount